Today, we're going to walk through one of the most clinically important and legally exposed skills in prescribing practice, assessing medical decision making capacity. This is where clinical judgment and ethics and liability all intersect. And importantly, this is not just a prescribing psychology skill, this is your responsibility as a prescribing psychologist. So these are today's learning objectives. We need to differentiate between medical decision-making capacity and legal competence, including their respective clinical and legal implications. Describe the core characteristics of capacity, including its decision-specific, time-specific, and risk-dependent nature. Identify clinical scenarios in which a formal capacity assessment is indicated, including cognitive, psychiatric, and acute medical conditions. Define and explain the four domains of capacity: choice, understanding, appreciation, and reasoning as outlined in the Appelbaum Grisso model. So I want to start here by clearing up one of the most common areas of confusion: capacity versus competence. So capacity is a clinical determination. That is what you assess. Competence is a legal determination. That's what a court decides. What matters for your day-to-day practice is capacity. And capacity has three defining features. It is decision specific. Someone may have capacity for one decision, but not another. It is dynamic. That means that it can fluctuate over hours or days. And it is contextual. The level of capacity required depends on risk. So right away, we're moving away from an all or nothing mindset here when we are assessing capacity. You don't need to formally assess capacity with every patient, but you absolutely need to recognize when you should. You should be thinking about capacity when there's a reasonable concern about impairment. That includes things like cognitive disorders like dementia or TBI, or someone that has an intellectual disability, severe psychiatric symptoms like psychosis or mania, acute states like delirium or intoxication, high risk decisions, especially refusals of treatment, or when a decision just doesn't make sense in a context. So, one practical rule is if something about the decision makes you pause, that's your cue to assess for capacity. So, here's where we anchor this clinically and legally. And I'm going to focus on Idaho. So, in Idaho, the statutory standard focuses on whether a patient can comprehend the need for treatment, understand the nature of treatment, and understand the risks. What's important is that this maps really cleanly onto what's called the Appelbaum and Grisso model, which is what we use clinically to assess capacity. So even though the statute in Idaho doesn't explicitly name this Appelbaum and Grisso model, in practice, they are really aligned. So capacity is typically evaluated across four abilities. And the first one, the first domain, can the patient communicate a choice? This seems simple, but there are three things that you're actually evaluating. Is the choice clear? Is it consistent? Is it stable over time? A patient who gives you a different answer every 5 minutes does not meet this threshold. But, and this is critical, communication barriers do not equal incapacity. So if someone has aphasia, like they've had a stroke, or hearing impairment or language barriers. Your job is to adapt the communication, not just assume incapacity. Next is understanding. Can the patient explain what their condition is, what the treatment is, and what the risks and benefits are, and what the alternatives are? The key here is not whether they can repeat what you said, it's whether they can explain it in their own words. This is where the teach back method becomes essential. If they can't explain it, they don't understand it. And if they don't understand it, they don't have capacity. Next is appreciation. And this is where things often break down. Appreciation is about whether the patient recognizes that this information applies to them. So, like an example, a patient might say something like, I understand bipolar disorder, but I don't have bipolar disorder. That patient might have an intact understanding, but an impaired appreciation. This is really common in psychosis, mania, neurological conditions involving insight. A patient might have anosognosia. They might not understand that they have deficits. And clinically, this is often the decisive domain. Finally, reasoning. Can the patient compare options, weigh risks and benefits, and explain why they made their decision? Here, the key distinction: we are not judging whether the decision is good. Patients are allowed to make bad decisions. What we are evaluating is whether the reasoning process is intact. So a patient can refuse treatment for reasons that we think unwise and still have capacity. But if the decision is based on a delusional belief system, that's where reasoning breaks down. So this slide here is helpful conceptually. Again, although Idaho doesn't name the model, you can see how Idaho's statutory language maps directly onto those four domains of the Appelbaum and Grisso model. Comprehends the need, aligns with appreciation. Nature of treatment aligns with understanding. Risks aligns with understanding and reasoning. And the ability to consent aligns with communicating a clear choice. So clinically, if you assess the four domains, you're covering the legal standard in Idaho. One of the most important advanced concepts, capacity, is risk adjusted. So this is what we refer to as the sliding scale model. For low risk decisions, like maybe starting an SSRI, you can accept a lower threshold of capacity. For high risk decisions, maybe like refusing antipsychotics in severe psychosis, you need a much higher level of demonstrated capacity. So the question is not just, do they have capacity? It is, do they have enough capacity for this particular decision? So, as we take a structured clinical approach, before you even assess capacity, you need to rule out uh, reversible factors that might cause incapacity. For example, you should consider things like delirium, medication effects, pain, sleep deprivation, or substance use. Then you need to optimize communication. So when you're talking to patients, you should use simple, plain language. You should break down information for them into chunks that they can understand. You might want to address sensory barriers, like use visual aids if needed. Uh, Maybe they prefer written communication versus verbal communication. You should also check for hearing and vision barriers. If you don't do this, you might falsely conclude that someone uh, had incapacity. Okay, now we are moving into the actual capacity interview. When you are asking a person questions about capacity, you should use open-ended prompts. Don't use questions that you can just answer yes or no to. Use open-ended questions. Like, tell me what's going on with your health. What are your options here? What could happen if you take or don't take this medication? Why do you prefer this option? And then the next step, the most important step, and this is critical for liability. You have to document your findings, and your documentation should clearly map onto those 4 domains or abilities. And this is where liability lives. It's not in your conclusion, it's how you got to your conclusion. And that is in your documentation. And there are standardized tools like the MacArthur Competence Assessment Tool for treatment. I have this. It's on my shelf. I honestly I cannot remember a time that I've actually had to use this, but I don't work in high risk situations. Now, I want you to know who the authors of this are. It's not MacArthur, it's Grisso and Appelbaum. So, this is a good tool that maps onto their model. And this doesn't replace clinical judgment. And I'll emphasize that. Um, if you just rely on this tool without understanding the underlying model, you might actually be increasing, not decreasing your risk. So this is an aid, not a replacement for your clinical decision making. So some special considerations as a prescribing psychologist. Several key principles. First, psychiatric illness does not equal incapacity. Remember that. A person with schizophrenia may have capacity, they may not. The diagnosis doesn't matter. Second, refusal of treatment. Patients can make bad decisions and still have capacity. You need to focus on the process, not the outcome. Third, capacity can vary depending on the decision. Starting medication versus refusing versus adherence. And fourth, capacity can fluctuate. So we have a lot of conditions where somebody's mental status might change. The best example for me is delirium, but maybe somebody is in a manic episode or experiencing a major depressive episode or intoxicated. Reassessment is essential. So what do you do if a patient lacks capacity? Well, then you move to surrogate decision making. But remember, capacity is still decision specific. And if capacity returns, authority immediately returns to the patient. So if you are moving to surrogate decision making, here you would apply what's called substituted judgment, what the patient would have wanted, or best interest if that is known. And in high risk or unclear situations, you involve legal or ethics consultations. If you work in like a hospital setting, they might have a ethics board that you are required to consult with. Now, surrogate decision making will be state dependent. So here we're outlining Idaho's surrogate decision maker hierarchy. So here the key takeaway is that there's a structured order of decision makers. And importantly, this only applies, again, when the patient lacks capacity and there's no advance directive in place. I know you've heard that term, advance directive. So a patient can outline what they want to occur in the future in the event that they lack capacity. And this is where legal knowledge intersects directly with your clinical role. So again, each state would have this. Here's the Idaho statute, and you can see the hierarchy there. One, court-appointed guardian, if one exists, spouse, adult child, parent, any relative representing themselves as appropriate, another competent individual representing themselves as responsible for the patient's care. Okay, so this is the slide that should make you slightly uncomfortable, because really this is where clinicians get into trouble. They fail to document their rationale. So it's not just the conclusion, it's the thinking process that gets to that conclusion. And you should always link findings explicitly to those 4 abilities. You should document efforts to enhance a patient's capacity. You should reassess when their clinical status changes. And then consult when uncertain. Consultation is very important if you're unsure. So there are lots of failure points. Poor documentation, assuming incapacity based on diagnosis, failing to reassess. So the best practice, again, document your reasoning, link it to the 4 domains, document efforts to improve capacity, and consult when needed. All right, so at the point of care, you might not always have time to do a full capacity evaluation. So use this quick clinical heuristic. Ask yourself, can the patient choose? Do they understand? Do they appreciate? And can they reason? If any of these are questionable, if you pause at any of them, if the patient fails any of them, then you should slow down and assess more fully and potentially perform a full capacity evaluation. And if that fails, then you move on to a surrogate decision maker. So, at the end, a concise way to frame this, and this is what I'll leave you with, is capacity is about the process of decision making, not whether we agree with the decision. Again, patients have the right to refuse treatment. Patients have the right to make decisions that are different from yours. And if you anchor yourself in the principle of the process of decision making, you'll avoid most of the common pitfalls in this area. And again, document this in your notes. So that's it, the quick lesson. I hope you found that helpful.